Dr. Folprecht from the University of Dresden. He is a medical oncologist, and now he changed his role and speak as an epidemiologist of colorectal cancer, risk factors, genetics, and predisposition. Dr. Folprecht.
So, thank you. So, as you explained, I'm not an epidemiologist, but we all as physicians have sometimes the task to explain why. And what is perhaps interesting for us in Europe is we have not the same distribution of colorectal cancer. This is, for example, the incidence in blue and the mortality in red for men. The distribution is similar according to the relationship between the countries for women. And you can see that in Western Europe and in the northern countries, the incidence of colorectal cancer is much higher than the southern and in the less developed parts of Africa. In Europe, we know very well that colorectal cancer is one of the most frequent tumors. You see the larger cycle for the incidence of colorectal cancer. So it's the third most common cancer type in men, following after prostate cancer and lung cancer. And according to the mortality, it's the second most frequent cancer type after lung cancer. This is similar in women. However, prostate is exchanged by breast cancer for the incidence, and in the breast cancer mortality plays the major role in women dying from cancer. In women, it's a head-to-head challenge between colorectal cancer and lung cancer, and in the countries where the women are smoked a little bit more, lung cancer becomes much more common. So even in Western Europe or in the European Union, you can see that the incidence of men is much higher than for women with colorectal cancer, and that also within, for example, the Eastern European countries, there are large differences according to the incidence and also to the mortality of colorectal cancer. The question is why, and we will learn perhaps a little bit later some on the reasons. It has to do with our lifestyle, and you can see that after the breakdown of the wall, there was an increase in some countries of colon cancer. It was more stable in the Western, Eastern countries, and also in Southern Europe there is an increase, perhaps with the change of the lifestyle. We don't know exactly, of course, the reasons, because these are just observational studies. You see that the trends, according to colon and rectum cancer, are quite similar over the time in Europe for both diseases. This is completely different to other cancer types, and you can see on the left side that, for example, you know it, for patients with gastric cancer, we observed that the incidence decreases by a lot. This is the other data from the SEER database, which are interesting because they followed a longer time period. And you see that from the mid of the 70s to 10 years ago, there was a decreasing number of colorectal cancer patients. And on the right part, you see the probability to survive 5 years. So the probability to survive increased a little bit between the mid of the 70s until 2000. In this model, the investigators tried to show what might be reasons for the reduced mortality. And the highest mortality according to colorectal cancer was in the late 80s, and it decreased, and there might be some effects of the screening, and there might be a reduction of risk factors. We will learn later on which are important risk factors. In this model, the contribution of our treatment to the reduced mortality is perhaps much less than we as treating physicians estimate. What are typical risk factors? We all know that hereditary cancers contribute to colorectal cancer incidence and mortality. However, when we talk on this topic, we have to remind that most colorectal cancer is sporadic, and that the hereditary colorectal cancer patients contribute only to a minority, especially with the familial adenomatosis, adenomatosis polyposis, and the other very well-defined diseases are extremely rare. Much more common in blue are the non-polyposis hereditary tumors, and we know, of course, also some gene defect or gene mutations that can contribute to HNPCC. This is MLH1, MSH2, and MSH6, and then few other much more rare mutations. And what is also important if we follow up patients is that we can find a pathogenic mutation only in a part of the patients, and that some patients have a change in the gene, but it's still unclear whether this contributes to the disease or not, whether this is a driving mutation or not. Patients with HNPCC have a cumulative risk of colorectal cancer over their life of above 30 to 40%. You see it here for men and women. And for us as GI oncologists or GI treating physicians, it's important to remember that there are other tumor types that are frequent and have a similar life risk to get endometrial carcinoma or ovarian cancer. The risk to develop such a cancer depends on the mutation. You can see here that not all mutations have the same risk to develop later on colorectal cancer. So MSH6 is much less frequent, to much less, lower probability to develop colorectal cancer, or for example endometrial cancer, than for example MLH1. So of course you all know the Amsterdam and Bethesda criteria. I want just to remember that if you have several relatives, younger patients and so on, that then it's important to follow up the patient more closely. And this is the German recommendation that if you have a patient with the first suspicion of HNPCC, then the first question is whether he met the Amsterdam criteria, which are more strict. If not, the next question is whether he had fulfilled the Bethesda criteria, and then there would be the test for a microsatellite instability. If it's positive, then the patient will or has to follow the recommendation for the much more intensive screening for HNPCC and the follow-up. And the further procedure depends on the immunohistochemistry. If you can show a definite gene defect, you can test for BRAF. If the patient has a BRAF mutation, he can just follow up according to the usual guidelines for sporadic colorectal cancer. If he has no mutation, then you can determine whether he has a pathogenic mutation, and if yes, it's important because you can then propose a predictive testing for their relatives to avoid or to recommend the more intensive follow-up or screening programs for HNPCC patients and relatives, which includes the physical examination, but especially the colonoscopy, gastroscopy, and the gynecological examinations. There are other hereditary syndromes which are interesting from the perspective of science, which are important for these families, but which are extremely rare. So the familial adenomatosis polyposis syndrome, or the other much more less frequent syndromes. And there are special recommendations. I think it's not very sensible if we review them now. Another important cohort of patients are those with chronic inflammatory bowel diseases, because although these patients have a very high risk to develop colorectal cancer over time, you see here the years after diagnosis, and you can see that for the most of the patient, the risk to develop colorectal cancer increases after 10 years. And for patients who had an early onset of the ulcerative colitis, the risk to develop colorectal cancer over their life is more than 30%. And this meta-analysis shows again that the relative risk to develop a colorectal cancer actually depends on the time after onset of the diagnosis. So this is overall up to 10 years, the risk is only slightly increased, but after 10 years, the risk increased between 15 to, by the factor 15 to 20 or even 20 to 30 compared to the normal population. Endoscopic surveillance is one option, and the other ones are, of course, to treat the underlying disease and to perform a chemoprevention with the usual drugs to treat ulcerative colitis. The last part should be lifestyle and other risk factors that are related to our behavior, because I think it's very important in education of patients, families, and our population. The first question is, has smoking to do something with colorectal cancer? You know, smoking is a risk for several cancer types, but it even increases a little bit the risk of colorectal cancer. So the hazard ratio to develop colorectal cancer in smokers who still smoke compared to people who never smoked is 1.2. So if you stop smoking, you can reduce your probability by something like 1/7. So, and you can even decrease your risk to die from colorectal cancer by 1/5. The risk to die from colon cancer, according to smoking, depends on the time the patient smoked. So if they smoked a long time, the risk increases by much more than patients who had only a short time of smoking. Physical activity has to do with the probability to get colon cancer. This is the incidence of colon cancer and physical activity. Patients who are active have a lower probability to get colon cancer. The hazard ratio is 0.75. So if you are active, you do sports, or you have physical work, you have 25% less probability to get colon cancer. And this data had been corrected to obesity and to age, and this is important because obesity and risk to get cancer was investigated over the last year much more than in the previous years. And you can see here that there are several cancer types that are related to obesity. Of course, esophageal cancer, but the third most increased risk is for colon cancer in men, and it's less prominent in rectal cancer, for rectal cancer, but it's still a hazard ratio of 1.1. But obesity, the increase of the BMI by 5 increases the risk to get colon cancer by 25%. So, if you have if you compare a severe obese patient with a BMI of 35 to patients with normal weight, they have this 2 times to increase this hazard ratio. For women, this relationship for colon and rectal cancer is a little bit less prominent, but there are, of course, other cancer types, it's endometrial carcinomatosis, for example, that are much more frequent in patients who are obese. Alcohol, you would first think alcohol is typically not related with colon cancer, and there's also not a very strong effect. If you drink 1 bottle of wine per day or 2 liters of beer, you have an increased risk to get colon cancer. The hazard ratio is 1.38, so nearly 1.4. But of course, there are other cancers that are much more likely that you will develop them. For example, for women breast cancer, the risk with the same amount of alcohol would be with a hazard ratio of 2.5. And of course, you know all the other cancer types as oral head and neck cancer or esophageal cancer, which are much more prominent, and look that the y-axis has another there 7 the risk ratio instead of 3. What are mechanisms? I like the slide because it explains everything I showed on the last slides in one figure. These authors think that everything has to do with the inhibition or activation of COX by obesity, physical activity, and so on. I'm not completely sure whether this model works, but it would explain that aspirin could perhaps reduce the risk to get colorectal cancer. You remember probably that 1.5 years ago, this slide was published in the New England Journal, but this is for patients who had colorectal cancer, and the PI3 kinase mutation was determined in these cancers, and this is, let's say, adjuvant treatment by aspirin. But there, from the studies investigating cardiovascular diseases, data on the risk of death from cancer. And interestingly, although these patients have a better outcome for cardiovascular disease, they have also a lower risk to die from from cancer. You can see there is a difference, which is statistically significant, but the absolute difference is quite low. So after 10 years, the difference is less than 1%. For colorectal cancer, the difference, if you want to perform this multi-testing, is even a little bit higher. So the p-value is 0.0007, so it's statistically highly significant, although the absolute difference is quite small. So after 20 years, the risk to die from colon cancer with or without aspirin differs by a little bit more than 1%. So of course, it's not the general recommendation, but it's interesting for the patients. So perhaps when you want to start to take aspirin, perhaps you want also to take vitamin A, C, and so on. And because this is a very common question of my patients, I want to show you this meta-analysis, and you can see I've seldom seen a risk ratio of 1.00, exactly the same risk whether you take it or not. So you can explain you should not waste your money on these pills, perhaps better not to buy cigarettes and to buy some shoes to run. What are other options? Of course, colon cancer screening.
Dr. Folprecht, 1 minute left.
It's okay. Colon cancer screening is important. This is with the traditional methods, the fecal blood test. This is why colonoscopy. You all know better than me that colonoscopy protects from colon cancer. This is a hazard ratio of 0.6 in patients who had it. And because we all have stress, I want to reassure Professor Schlag that work stress has not a major contribution to the risk of cancer. You can see in general it's very close to 1. And I want to give you a last recommendation how to avoid colon cancer. Don't smoke. Control alcohol and obesity. Perhaps you have a little bit less fun. Do sports or physical work. You can do it. You can also work hard. It doesn't harm you. And you can move to Greenland because in this map, there's absolutely no colon cancer. Thank you very much.
Dr. Folprecht, thank you very much for this nice overview and all your recommendations that we can prevent this disease. Okay, discussion afterwards. We discuss everything together so to keep in time. So the next